but we do economic evaluations because, and what we have up here is to inform real world decisions, but the honest truth of it is, right, is that at the end of the day, we really want to know policymakers from every level, whether you're, or stakeholders at every level. So whether you manage a clinic or you manage a government, part of what goes into your decision-making process is cost and value, which are very different, and we'll get to that in a little while. But in this world where we live in with limited resources, right, and it's not just now, this is an always thing, decision makers are in need of trying to figure out how they can best spend their money. So this is where the sayings like best bang for your buck come from. Knowing that each decision that you make comes with trade-offs. That if you spend your money in one place, maybe it's a high value place, but it means that you're going to have less money somewhere else. There can be different objectives. So for instance, there may be the clinical objective to reduce fatal overdoses, but sort of from a societal viewpoint, the objective may be to reduce ED costs from overdose events. So while they're tied together, you can see this tug of war that decision makers have. And so having objective cost data can be useful, or value data can be useful. On the bottom of the screen, what it also does in the decision-making process, which I certainly think we should and we do focus a lot of our energy on, is that it identifies relevant alternatives. So in this world where we can say, well, maybe this is the most valuable approach, or maybe this is going to give us the most fatal overdoses, but we can't necessarily pay for it. We can at least identify different approaches that will give a good clinical outcome, as well as taking into account costs. And because there's uncertainty around any decision we make in economic evaluations, we can help at least describe that uncertainty. And it just turns out that these days, health economics research is a very, very prominent funding feature for the NIH, for the same reason that we're talking about. We have a huge clinical and public health issue at hands with overdoses and with substance use disorders. And in order to prioritize where we put our resources, we really need economic evaluations. And so you can see there are a number of HEAL initiatives that many of you are involved with the healing communities, but we talk here in Massachusetts and in New York, we talk about the CTN trials all the time. There's the new Justice Community Opioid Innovation Network, which is all about opioids in criminal justice setting. And then, as we talked about earlier today, there's at-risk adolescents. And so these are the main priority areas for NIDA right now. And it happened to be, just out of luck for all of us, it happened to be a major aim of the HEAL community study. And what we're working through now, and what we spend, 20 to 40 to 3,000 hours on a week, are working towards these 4 aims. So calculating the incremental cost of evidence-based practices relative to standard practice, and we'll talk about some of these definitions in a bit, in the healing community study. Conducting cost-effectiveness analyses of evidence-based practices, estimating the medium and long-term clinical effectiveness, cost and cost-effectiveness of these interventions from multiple perspectives, and evaluating the sustainability of integrating these approaches. So this factors in prominently with a lot of work, not just with healing communities, but in much of what we do. So there are a couple issues. I'm going to skip over efficacy, but just so that we're on the same page. Efficacy is really, can it work? So if I have a new drug, we have to test and see, does this actually work in sort of a controlled setting? We're not dealing with efficacy in healing communities, and in many of the studies that we do here or in New York or Ohio or Kentucky, we know that naloxone reverses overdoses, so we can sort of move on from that. But we are looking at effectiveness and availability. So does this work in the setting and from the perspective that we want it to, or that we're hoping that it will, or that we're implementing it? And is it actually reaching who needs it? So those last questions, the effectiveness and the availability, those are things that we're focusing on more than the efficacy. And talking about cost analysis, cost effectiveness, and cost benefit, this is, I'm sure that many of you have, you talk to your parents, or you talk to somebody, a friend, and they say, oh, doing that would definitely be cost effective. But there are specific definitions of what we mean by cost analysis, cost effectiveness, and cost benefit, which I think are really important as we're talking about this in a research structured setting, to really start to understand. So a cost analysis taken just by itself is, you don't care about the effectiveness, you just care about the cost, right? So it focuses on the cost of an intervention without measure of effectiveness from a stakeholder perspective. From a cost analysis perspective, or a cost analysis just says, how much does this thing cost me? Forgetting about person life or quality adjusted life years or any of that. A cost effectiveness study, and all of these are economic evaluations, but a cost effectiveness study is when we start taking in the cost and the effectiveness, right? So it's that first time that we start to think about it, of a program compared to at least one alternative. So, and we look at this, we talk about the incremental cost effectiveness. So how much, the delta, how much does this cost compared to another program over the effect that you're looking for, the change in the effect. Those outcomes that those health outcomes that we're talking about, you'll hear QALYs. We've talked about QALYs quite a lot over here, but it can be cases of a disease prevented, years of life gain, quality adjusted life years. But these aren't necessarily monetary measures. And that's the key distinction between a cost effectiveness analysis and a cost benefit analysis. And it's essentially the same sort of thing, except that we put costs on the effectiveness as well. So it's cost over costs. So again, that's a quick rundown. What we will be mostly focusing on in healing community study is cost effectiveness. We get to play around and figure out what our denominator is going to be, though. So all of this is nice and fun to talk about, except that what we really care about is who the decision maker, who the stakeholder is. Because what it does is it dictates which resources we include, and how to value them. And without going through all of these examples, you can see that there are multiple perspectives that you can take. I'm going to talk about the societal perspective because I think it's the most convoluted. From the patient perspective, which is a little bit more straightforward. So from a patient perspective, it's how much did this cost? How much did this intervention cost me? How much did I lose by not going to work? How much did I lose by taking the bus? How much did I gain? From a societal perspective, we really have to take into account everything. And that includes criminal justice, the criminal justice system, social services, etc. And Sarah did a lovely job putting this slide together because it really helps you understand where all of these different perspectives lie. So these are the various different perspectives. And what Sarah's done here is you can see that within the societal perspective, it includes healthcare, it includes programs, and programs can mean syringe exchanges or a clinic or whatever it is that we happen to be wherever we happen to be intervening, providers and patients. And you can see how each one of these are sort of couched and buried within each other. And what this does, this panel on cost effectiveness in health and medicine really puts out the major methodologic practices, how to do a cost effectiveness analysis. The reason we spend so much time talking about perspective is because the second panel recommends at least two perspectives, oftentimes, and what they recommend is the healthcare perspective and the societal perspective. So let's take a minute, because now we can start to think about why we go into such minutia with how we're going to collect costs, and I don't mean minutia in a bad way. We go into the sort of nitty gritty, because when we talk about societal perspectives, we're dealing with every layer of government and every layer where costs may become a factor when we deal with the healing community studies.
All right, so now we'll transition to thinking about cost effectiveness. So we've talked about the different types of costs, maybe some ways of collecting costs, and then what do we do with that data? So cost effectiveness is all about thinking incrementally, which, as Josh mentioned in the beginning, it's all about comparing one thing to another thing. So nothing can be cost effective on its own. It's how does this compare to either what we're already doing or some other intervention. So CEA is examining the net effect of substituting one option for another. We're looking at costs for competing programs. So for every increase in for every dollar, how many overdoses do we prevent? And cost effectiveness is reported in incremental cost effectiveness ratios, or ICERs. And so what this is looking at is the cost of one intervention minus the cost of the other intervention, or the control, divided by the effectiveness of your intervention minus the effectiveness of whatever you're comparing it to. So it's not crazy math, it's just this very simple ratio. Of course, there's a lot of work that goes into getting those numbers, but this is essentially what your output is.
And just a quick note that startup costs are not included in the ICER. It's important to know. Startup costs are not included in the ICER. We report them separately, and that's part of implementation.
So what do we mean by effectiveness? I mentioned one thing, preventing overdoses or something. There are a lot of different measures for effectiveness. It's really all about what is the objective of our program? What are we really trying to do? And who are the stakeholders and the decision makers? What do they care about? What do they want to know that they're, improving or saving for their money? We want to know, is it generalizable enough to inform how they allocate their resources? Do we have enough information about the measure to determine whether it's a good value? And so when we're thinking about the Healing Communities study, we know that our big outcome is opioid-related overdoses. And so effectiveness for us, we have lots of outcomes, right? Well, there's a lot of different things we're looking at, but you may think about the big thing being how much does it cost to decrease for each opioid-related overdose averted.
But important to note here that decision making requires these outcomes to have an explicit or implicit value, so a price weight, and it's also important to have the cost per outcome desired or outcome of interest to make these decisions, especially in healing communities.
So cost effectiveness, again, is all about value for the money. It's not about, does this save money? Is this is this good for, does this have a good effect? It's all about what effect are we getting for our money? Am I getting a good bang for my buck? So there's actually very few health interventions that save more money than they cost. So, when you put out a new intervention, most likely it's going to cost more than whatever the standard of care is. But the question is, do I get a good enough value from that? Am I saving enough lives? Am I improving quality of life enough to justify that cost? So it's all about comparative assessment of worth, and thinking about, we have scarce resources, and so we need to be able to make these decisions.
And one more important note is that even if that's not an intended outcome of our intervention, it's a cost upfront to us as the healthcare sector to deliver these interventions, but it's a cost saving to another group. So it's all about, again, just going back to perspective, it's all about perspective. So I might be putting the upfront cost and I might ultimately be the loser of that money, but someone down the line is benefiting from that. Sorry.
And then the final thing about cost effectiveness is, how do we decide if something is cost effectiveness? And we use this idea of the willingness to pay. So essentially, how much are we willing to pay for this certain effect? So there is technically no sort of cutoff. You may see cutoffs in journals, or you may hear people talk about like, oh, $50,000 for, quality adjusted life year or something. But it kind of depends on your stakeholder, and it depends on what you're talking about. And so it's really based on the decision maker. You have to put values on things and decide what is our willingness to pay for this